안녕하십니까. 공유의사결정 사업단의 탐목장을 맡고 있는 홍석철입니다. 오늘 사업단이 주최하는 해외 연자 초청 세미나에 참석해 주셔서 감사합니다. 오늘 그 세미나는 공유의사결정, 다양한 문화와 임상 현장 속에서 어떻게 이해하고 적용할 수 있는지를 함께 고민하는 시간을 갖도록 하겠습니다. 오늘 연자로 모신 분은 홍콩대학교 사회학과의 웨이웨이루 박사님으로 중국 내에서 공유의사결정 발전과 내러티브 접근에 대한 연구를 중심으로 오늘 발표를 진행해 주실 예정입니다. 먼저 발표 전에 그 웨이웨이 루 박사님을 먼저 소개해 드리겠습니다. 루 박사님은 그 환자 의사 공유의사결정 관련 그리고 커뮤니케이션, 내러티브 메디신, 의료 윤리 등의 분야에서 활발한 연구 활동을 이어오고 계시고, 최근에는 그 암 환자와 의사 간 치료 결정 과정에서 의미 해석 차이, 분열된 내러티브를 분석하고 공유 의사결정 모델을 통합하는 연구를 진행하고 계십니다. 오늘 발표 주제는 Shared Decision Making in China Towards a Narrative Perspective라는 제목으로 중국의 문화적 그리고 제도적 맥락 속에서 공유의사결정이 어떤 방식으로 정착되고 있는지를 같이 살펴보는 내용입니다. 그럼 루 박사님 모시고 세미나를 진행하도록 하겠습니다. 박사님 발표는 한 40분 정도 진행할 예정이고, 이후에 질의응답 시간을 갖도록 하겠습니다. 발표 중에 궁금하신 내용은 메모를 해주시고, 채팅창을 통해서 질의를 해주셔도 되고요. 이따가 직접 질의를 해주셔도 되겠습니다. 그럼 지금부터 닥터 웨이웨이 루의 발표를 시작하겠습니다. 네. 닥터 루?
Yeah, thank you, Professor Hong, for your introduction. I'm very happy to have this opportunity here to share my study.
Simple, and you start your presentation.
Okay.
Yes.
Yeah. Yeah, so good afternoon, everyone. I'm Weiwei Lu. I come from the University of Hong Kong Sociology Department. So today, I'm very happy to have this opportunity to share my research. And my presentation will include two parts. First, I will briefly review the shared decision-making research in China. And the second part will be my sharing of my research about a narrative perspective of treatment decision-making between physicians and cancer patients. Doctor-patient communication, I think maybe all of us will agree, is the core of healthcare. So a good communication between doctor and patient will lead to effective treatment and also the healthy relationship between them. It will also improve healthcare outcome and also people's well-being. And moreover, it will also help cultivating caring culture in hospitals and also will provide equitable resources for all the people. So doctor-patient communication plays a very important role from the diagnosis of the illness to the completion of the treatment. So it influences all aspects of our healthcare system and services. However, in reality, doctor-patient communication may encounter many challenges. So in Hong Kong, we have a very famous quote about the difficulties in mutual understanding. It's just like a duckling talking to a chick. So it means when two people communicate with each other with two language systems, with different mindsets, it will be very difficult for them to understand each other. So this phrase can also be a metaphor of doctor-patient communication because patients and doctors, they have different knowledge systems. So how to deal with this, how to respond to this difficult in communication, which is also very universal in both happening in the East and the West. So the concept of shared decision-making can be a positive solution to respond to this difficulty. So these concepts actually emerged with the trends in the medicine of patient-centered approach. So the fundamental principle of shared decision-making is to respect patients' autonomy. So we believe patients are individuals who will be able to self-determine their treatment options, and they will be able to make rational choices when they have enough information. So when respecting their patient autonomy, shared decision-making aims to achieve mutually agreed treatment decision, which based on patients' preferences. So in this way, shared decision-making actually promotes information exchange between doctors and the patients to try to help them make proper decisions. Then based on these common grounds of shared decision-making, so many shared decision-making models are developed. We can look at this slide. On the left side is the 3-talk model developed by the researchers from the Dartmouth College. In the middle is the purpose for shared decision-making model, also developed by research team from the Mayo Clinic, and also other kinds of shared decision-making models developed by scholars from Europe or other places. Then with this positive expectation on shared decision-making, this concept was also introduced to China in 1998. So since then, scholars have proactively discussed and explored the conceptual and theoretical meaning of shared decision-making. So this concept has received profound responses in the field of medical research and practice. Since 2013, clinical shared decision-making research has been conducted in multiple fields, including cardiology, orthopedics, oncology, and diabetes. And since 2018, the meetings, mini-conferences, and seminars related to shared decision-making have quickly increased, widely spreading the concepts of shared decision-making in China. Then there was a study in 2016 mentioned that the proportion of patients who prefer shared decision-making in China is already about 67.7% to 88%. So along with the interests in shared decision-making concepts, there are also decision aids and evaluation tools applied in local context. So decision aids mainly about information-based decision aids like the booklets and also the websites, which can provide pros and cons of treatment options. Then evaluation tools are also applied in the local studies, including the decisional conflict scale, option 12, collaborate, SDM QDoc. So these tools are also showed or examined in the local clinical contests and were published in journals, in Chinese journals. So the current situation in China is China's decision-making aid framework currently lacks a unified standard, and also the evaluation tools are still in the development stage. More importantly, there are no legal and medical regulations on shared decision-making in China. The challenge is very easy to understand because I think this is similar in other Asian countries or other Asian contexts. It's about the adaptation and the localization of shared decision-making. So in China, the current situation is there is a lack of evaluation skills that can be adapted to local contexts. And also there's an urge for a local theoretical system of shared decision-making that can conform to China's medical background. So we actually need a more comprehensive survey and research on participating subjects, for example, physicians, patients, caregivers, and nurses. And we also believe design, evaluation, and analysis of decision aids should be based on local language and also our medical and social background. So according to China's reality, family-centered shared decision-making should be considered. And also some study actually mentioned that we can even more aggressive to develop a model involving physicians, nurses, patients, and caregivers. So the implementation of policies needs integral efforts from all the stakeholders. including government health policy making, physician associations leadership, health commissions supervision, medical insurance department cooperation, and the medical schools establishment of systematic courses. While facing these challenges, we can also see positive scaffolding foundation of the development of shared decision-making in China. With the increasing interest in a professional area, that means a lot of professionals are now mentioning shared decision-making and even want to apply it in their contexts. And also the implementation, there are actually plain practices of shared decision-making. So we can see this increasing interest and behavior showing us we actually have a foundation to develop shared decision-making framework in the local context. So we can see some detailed situations. First, in China, now medical humanities are regarded as part of strategic planning in hospital management and development. So under this medical humanities, there are two streams of practice. One is narrative medicine, which is originated from Rita Sharon from the US. I think most of us will know that. And another stream is narrative practice in medicine, which is originated from narrative therapy in Australia and also some practice from England. So this a narrative approach actually emphasizes patients' illness experiences and also patients' voices in medical context, so which naturally leading to shared decision-making practice. Then second is about the bioethics field. In this field in China, now we are actually establishing the ethical principle of doctor-patient partnership. And also some studies show that 73.2% of medical staff recognize that patients are the important participants in high-quality clinical decision-making. So this background or these trends in the current bioethics field also lead to shared decision-making practice, which is aligned with our ethics principle and also the current recognition from physicians. And the third foundation comes from the traditional Chinese medicine. So China has a long history of compassionate doctoring. So this actually built the foundations for shared decision-making. And the last point, I think is also the most important point, is the plain practices of shared decision-making among experienced physicians. During my field work, I find many experienced physicians, actually, they are already practicing shared decision-making, even though they didn't use this word. Then this shows that we actually have a lot of good examples of local shared decision-making practice. So we can actually theorize their practices, we can structuralize their work, and we can also make them into guidelines for other physicians to follow or to take references. Okay, so that means we actually have great opportunities ahead of us to develop local theory and practice of shared decision-making. Then in this big picture, situated in this big picture, what can I contribute as a shared decision-making researcher? So after reviewing the Western literature of shared decision-making, I realized the underlying assumption of most of the current shared decision-making models is the rational choice theory. So which, like I mentioned before, which assumes human beings are independent individuals who can make rational choices when they have enough adequate information. However, this assumption actually doesn't work in our relational culture. So how can we develop a new model of shared decision-making which can adapt to our relational culture? So this is the question I was thinking about a lot. So since I have a background in narrative therapy, then I realized narrative therapy has a deep root in social constructivism. Then the philosophy of social constructivism actually resonates well with our Oriental philosophy called Taoism. So they all emphasize relational nature of our human beings. So I realized actually narrative can be a shared perspective between the West and the East, because narrative is a meaning-making method that every person actually practice in their daily life. So as Lao Tzu also says, a journey of 1,000 miles began with a single step. So develop a new model of shared decision-making from a relational perspective is a long journey. So my first step is the study I would like to introduce next, the encounter of two worlds, investigating the divided narratives between physicians and the patients on cancer treatment decision-making. So we go back to this picture again. So in doctor-patient communication, there are two voices. This is an argument proposed by Elliot Mishler, a social psychologist from Harvard University in 1984. So one voice is from the physician representing the professional knowledge, learning from the scientific world. Then another voice comes from the patient representing their illness knowledge from their life world. So these two voices demonstrates divided narratives between physicians and the patients as a divergent meaning-making of illness and treatment, which will also hinder mutual understanding and agreement over the illness and its treatment. So currently, little investigation compares the meaning-making of illness and the treatment between physicians and the patients, not to say taking divided narratives as a phenomenon and a method in physician and the patient communication. So my study is to investigate the similarities and the differences in these divided narratives. So my study is a qualitative research design of narrative inquiry. The data includes interviews with 32 cancer patients and 16 paired physicians in 2 hospitals in China. The data analysis was conducted using grounded theory, and there's a total of 12 types of cancer covered in this study. Let's look at this table. It's about participant information. So we can see physicians are coming from 4 medical departments: medical oncology department, surgical oncology department, radiation department, and also gynecology department. Then there are 11 male physicians and 5 female physicians. The age range is from 25 to 55, and the average age is 37.3 years old. And also average working experience is 12.8 years. Then about patient participants, we can see they are housewives, company staff, construction worker, retired people, self-employed persons, and farmer, electrician, mason. So number of participants we can here see there are 11 male patients and 21 female patients. The age ranges from 32 to 78, and the average age is 56.7. So the sample is actually quite diverse. So this study identified similarities. There are two common elements in divided narratives between physicians and the patients. One is goal setting, one is obstacles. And under each element, there are 4 sub-themes, both mentioned in physicians and patients and treatment decision-making process, and also 4 sub-themes about obstacles. So regarding goal setting, the 4 common issues are decision pools, treatment goals, identity practice, and a preferred identity. And regarding obstacles, there are 4 common issues about patients and trust, communication gap, financial issues, and a complex family. So even though they have 8 common themes in their divided narratives, then whether they interpret the meanings of these 8 themes in the same way, this is a question, and the answer is very clear. The interpretations are quite different. So let's look at them one by one. First, the difference is about the decision pools for goal setting. So decision pools refer to the potential cancer treatment choices physicians and patients have in their scientific world and life world. So for physicians, the question for them is about whether to choose plan A or plan B. A physician says, as clinical physicians, we will not give up treatment if we have a glimpse of hope. To cure patients is the original and a basic responsibility of a physician. Then for patients, the question for them is about whether to take a treatment or not, like a very classic question, to be or not to be. So a patient said, chemotherapy is like a fight with the enemy. When you kill 1,000 cancer cells, you will also lose 800 healthy cells. So when this session is over, I will quit. This is my decision. Then the second different interpretation is about treatment goals. Treatment goals mean physicians and patients set different goals for cancer treatment. For physicians, they mainly focused on medical goals of treatment. Physicians set medical goals of treatment to relieve symptoms, control disease progression, reduce side effects, and ensure medical safety. The aim was to improve patients' quality of life and ensure they could die with dignity. But for patients, they're more concerned about relational goals of treatment. While mothers underwent treatment to maintain a body condition to help young generations earn money, fathers stopped the treatment to save money for their children's future education or marriage. Grandparents also contributed to their families in various ways. For example, a breast cancer patient repeatedly urged her physician to perform her surgery because she wanted to pick up her granddaughter from kindergarten as soon as possible. Then third is about identity practice. Identity practice means how cancer treatment decision-making orients to the different aspects of identities. So for physicians, treatment is a process for them to construct patient identity for ill people. That means they want them to perceive themselves as patients. As a physician said here, we will share the diagnosis with patients. If they know the truth, they will be quicker to accept their role as patients and follow our treatment plan. But for patients, they actually want to perform their original identity through treatment. That means they want to be themselves as usual by taking treatment. So a patient said here, I live in the moment. Every day is a bonus. I could eat and exercise. I did not expect an affluent life, just a peaceful and healthy life, like any other ordinary person. Then the fourth one is preferred identity. Preferred identities describe the roles physicians and patients prefer to play in achieving goals. So for physicians, they usually want to be good physicians. That's why they make efforts to practice their roles and their jobs. So as physician said here, to cure sometimes, to relieve often, to comfort always. In my 20 years of medical work, I dedicated significant time to communicating with patients and comforting them. As I know, complete cure cases are rare. But for patients, whether they want to be good patients, this is the question. Let's look at this example. The patient said, I was determined to live a quality life once I knew I had this disease. I don't dare to say that I will live until I am 100 years old. At least I wish to live independently without bothering my children. So here we can see the patient actually prefers to play a role as a parent, not a good patient. Then we talk about the different interpretations of obstacles. First is about pain and trust. Pains are obstacles for both physicians and patients in achieving treatment goals. Pain management influences the trust between physicians and patients depending on how much they can control the pain. For physicians, they actually control the pains to win trust and to improve patients' adherence. So a physician said here, the first thing is to reduce the patient's pain. If the pains are controlled well, patients will have high adherence to the treatment. But for patients, actually, they experience dual pains. A patient shared here, there is 30% physical pain and 70% mental distress. I have a colleague who was diagnosed with pancreatic cancer. He immediately collapsed after the diagnosis. Within a month, he passed away from there. Then second is about communication gap. The communication gap demonstrates the different aspects of communication that physicians and patients identified as obstacles. So for physicians, they made their efforts to make patients understand like the cause of the disease and the reason of the treatment and the pros and cons of the treatment options. So like a physician said here, we could explain the disease to them at different places. You can talk to them in the office. You can talk to them in the ward. They can sit down to listen to me. So he thinks possessing a good attitude would improve the effectiveness of communication. So they made a lot of efforts to make patients understand. But for patients, the problem is that they are fearful to talk to the authority because they respect physicians as authoritative persons. So as a patient said here, I must believe in physicians. It is the same for every patient. Physicians are supposed to take care of patients. The most important thing is their morality. I believe all the physicians in hospitals are good. Therefore, we need to obey their instructions, no doubt. Then the third obstacle is financial issues. Physicians perceive the financial affordability as a determinant of treatment decisions, while patients evaluated treatment based on its worthiness. So here, one example, physicians will consider about whether it is affordable for patients to take this treatment. A radiation oncologist believed that her patient stopped the treatment because of money, because the patient is a single mother and didn't earn much. But it's the opposite. Actually, the patient shared that she was afraid of the side effects of chemotherapy, which she believed would shorten her life. Then for the patients, when they consider about the treatment, actually, they think about whether it is valuable for them to spend such a big amount of money to take treatment. So here's an example. The patient said, as a farmer, I do not have the money even to afford a bottle of water, but with this disease, I need plenty of money for treatment. My father got cancer last year. I spent a lot of money on him, which financially burdened me. This year, I got sick. I have an older mother to care for and 2 children to nurture. If I don't get treated and I die, my family will collapse. So you can see here the problem is not about money, it's about the meaning of the treatment. Then the fourth obstacle is complex family. Complex family covers various family situations that make cancer treatment decision-making mingled with risks, conflicts, and meanings. So physicians take complex family as a risk factor. So as a physician said here, families with multiple children are often risky. It is strange that daughters rather than sons usually bear the financial expense of medical treatment if their economic situations allow it. If there are multiple sons, the problem gets complicated. Some would like to pay while others would not. There will be conflicts. In some cases, they quit the treatment because of these complex family issues. Then for patients, family sometimes becomes their motivation to take treatment. So here's a patient example. It was meaningless for me to live long because of the conflicts with my husband. I did not want to live, but my relatives comforted me. They called me every day to encourage me. So I decided to live for my children and myself. So here's some discussion about this study. So this study actually demonstrates the encounter of 2 worlds between the scientific world and the life world. And also it identified 4 dimensions in divided narratives between physicians and the patients on their cancer treatment decision-making. the cognitive and emotional differences between physicians and the patients actually has been identified in previous literature. But this study identified two new dimensions, which are behavioral and existential dimensions, which means with different cognition and emotion, actually physicians and the patients will also have different behaviors and to deal with the situation, and they will also consider about their identities when they take these actions. So this study actually indicates that shared decision-making can advance information exchange to narrative integration. So this also informs which narrative integration means it can involve 4 dimensions in their real situations. So this study also informs a narrative perspective of shared decision-making, which emphasizes mutual engagement. So we can look at the diagram here. So outside the circles, we can see there are physicians and patients, and we can also see the dotted blue lines come cross together, then merged into a new line, which means a coherent narrative of treatment decision. So this is a process of narrative integration from the divided narratives between them. That means the divided narratives becomes a new coherent narrative. Then through this process, we can say they need to overcome the difficulties of power imbalance, knowledge difference, and also time limits in the clinical settings, and also cancer stigma in the society. So this shared decision-making model hopes to achieve the mutual engagements in these 4 dimensions. We hope physicians and the patients can mutually engage with their emotion, with their cognition, and also existential needs, and also behaviors. So this study also has some strengths and limitations. The strength of this study is the divided narrative approach, which is fully aware of the context of physician's scientific world and the patient's life world. By peer interview, this study controls the research context within the same event. That means the same illness, the same treatments, and also the same hospital, making the perspectives comparable. Then there are also some positive implications of this study. For medical education, divided narratives between physicians and patients can be included in the medical curriculum. Then for practice, supportive interventions can be developed to amplify patients' voices in treatment decision-making. The limitation of this study is its generalizability. The findings of this study can significantly contribute to implementing shared decision-making in Chinese communities. However, the similarities and the differences in divided narratives may vary from context to context. For example, what will be the similarities and the differences in divided narratives between physicians and the patients in South Korea? I think it will be different from the findings in this study in China. So it is worthy to explore what are the divided narratives in different contexts. To conclude, facing the uncertainties brought by the ever-changing events in the scientific world and the life world, it is essential to know how physicians and patients interpret the meanings of these events. A divided narrative approach can explore physicians and patients' meaning-making of illness and treatment in their complex contexts, providing compelling evidence for us to understand the meaning gap between physicians and patients. The narrative perspective indicates an attention shift from information to interpretation of information, which can further respond to the current technology trends in the scientific world and the life world. Shared decision-making model can shift from information exchange to narrative integration by emphasizing mutual engagement of physicians and patients. So if you are interested in more details, you can also scan this QR code to read the full paper and also search it on the internet. So about future research, we can, I think there's a vision there, includes a lot of things. For example, we can investigate divided narratives in other disease contexts and also other cultural and social contexts. And we can also investigate the development and implementation of the narrative-based model of shared decision-making in the local context, also in the international context. And then we can also investigate the integration of this model with new technology and AI. And I think these are very promising areas we can look forward to. Then this is also a long journey, as I said before. It's a 1,000-mile journey. But here I strongly welcome you to join this journey because I believe together we will go further. So thank you very much for your listening.
Thank you, Dr. Liu, for your nice presentation. 혹시 그 질문 있으시면 질문을 해주셔도 되겠습니다.
Hello. I'm Dr. Kim from Seoul National Bundang University. I am an endocrinologist, and thank you for your excellent research result and presentation. I believe that China share many cultural similarity with Korea as a part of the East Asian region. One such similarity is the important role the families often play in medical decision making. In Korea, patients often hesitate to make medical decisions themselves. Many are uncertain about their own preference, and as a result, they may expect physicians to decide for them or prefer the family member make the decision. How is the situation in China?
Thank you very much for your question, Dr. Kim. Yeah, I do think we share a lot of cultural similarities, especially family-centered culture. And a situation in China, in mainland China, I think it depends on the areas. The field work I did is in the northwestern China. So it's more, the situation is more about family members will make decisions for cancer patients. But my hometown is in the east part of China. So the situation is totally different because, as you said, some patients are very clear about their preferences. So in Eastern China, this is the situation that the power is more shared among patients and their family members. So they have more room to discuss about treatment together. And sometimes patients can make decisions on their own. Interesting in concept divided, could you? Yeah. Okay, thank you very much. So the divided narratives, as I mentioned at the very beginning of the presentation, is about meaning making of illness and the treatments. Then why I want to coin this term, because we seldom realize actually there are divided narratives. It's not just about knowledge difference, it's about meaning making between physicians and the patients. Because narratives are meaning-making methods, and the physicians and the patients, they not only have different knowledge, they also have different ways to make meanings of illness and treatment. That's why we need to look into the meaning-making process. So I propose this term of divided narratives. So it focuses on meaning making and different meaning making. Then I apply in this research because I think the tension between physicians and the patients are much stronger than the ordinary peers, like that interpersonal relationship. We also have divided narratives, but tension is not so big because the scientific knowledge and the patient's lay knowledge about their illness is not equally acknowledged. That's why I think it's very important to acknowledge they are divergent meaning making, than to understand or find solutions to improve their communication quality. Then whether it can be used in other cultural clinical settings, I believe so. I believe so because I think this divergent meaning making is fundamental. Not only about culture or clinical, it's fundamental in all the interpersonal communication. Thank you.
And I have a question.
Thank you. Yeah, Professor Hong.
Yeah, I could learn much about the narrative gap in SDM, China. China is very big country.
Yeah.
Yes. So is there any regional difference? And you should consider in the future study.
Yes, this is a very good question, and this is a very good motivation for future study. Because my study is conducted in northwestern China. Then the regional differences are very big because regional differences include economic differences and also educational differences and even cultural differences. So it is very important that in the future I should go to some developed areas in China to conduct the similar research, to compare divided narratives between physicians and patients in different areas in China. Then I can identify how the social factors like economic factors or education factors, socioeconomic, so a lot of socioeconomic factors, even age or gender, how they influence their divided narratives. So this is very important to consider regional differences.
It will be very interesting, I think. And one more thing is that you noted that the SDM currently lacks legal and institutional frameworks in China. What do you think is the biggest barrier to policy level support for SDM?
Policy level
support.
barrier.
Yeah, barrier. Yeah.
This is a very difficult question because a policy level is usually about social system and about different levels of social system, because how can you make a policy and how can you implement this policy? Like I said just now, it involves multiple stakeholders. So in each part, if the implementation of policy has problems, that means it will cause barriers to the implementation of shared decision making. So I think just because the system is very complex, it needs a lot of parties' efforts to make it come true. That's why there are a lot of barriers. But I think in the future, we need to identify which part we can find easier entries. That means not so many barriers to enter, so we can influence the whole system. So now what I can see is that like the insurance policy now in China is a big issue we need to consider. But this is also a very complex system. We cannot change it so easily, because you can see in the cases a lot of problems actually is about money. So this is the thing, it's a fundamental thing we need to consider in future policy making. But maybe the solution will not be there, but from other places.
Yes, in Korea we have same problems and constantly.
So we can share more, we can discuss more, we can learn from each other.
Yes, yes. 혹시 다른 질문도 있으실까요?
Oh, yeah, I saw. Intuitively. Thanks for your question. This is a very meaningful question because I think both China and Korea want to have this local model of shared decision making, which can adapt to our local contexts. And I think my research can imply that we can just I mentioned in my presentation, I saw a lot of experienced physicians, actually, they are practicing their understanding of shared decision-making in their unique ways. So during my field work, I saw a lot of people having done a very good job, which I think very perfectly perform the shared decision-making. So I think this is the part we can value, we can acknowledge, and as researchers, we can theorize their practices into frameworks. Because if they can do that in their settings, that means they can do that in our local context, they can do that in our cultural context. So that means other physicians can take references from them. So I think local experience is very important, which embedded in our own professionals' experiences. So we can explore more. We can learn from them how they can do so good job to perform shared decision making. So I think the main point is to look to dig your local wisdom, so you can gradually develop your localized model of shared decision making.
Thank you, Dr. Liu. Thank you for your response. One more question. I'm wondering, what do you mean by a coherent narrative? Because given the divided meaning gap, it might be very hard to harmonize two different approaches to treatment decision in clinical setting, right? So then, what can we expect about the coherence in narratives of disease and narratives of treatment between two sides of communicators, physicians and patients? I'm sorry about the noises. I have to ask.
Yeah, your question is very clearly heard. It's okay. Thank you very much for your question. I think this is also a very important question, because about coherence in the future, if we want to develop this model, of course, we need to measure. So we need to define what means coherence. So at the current stage, I cannot say we have a clear elements to measure it, but there are some clues to think about how to define coherence. Of course, you should be able to deliver a coherent message. So message will be very clear. That means when you have a coherent narrative, you will not feel confused about things. So this is one thing. Then another thing to measure coherence is about identity construction, because here I mentioned many times about identity construction and also preferred identity. So why we need to mention preferred identity? Because if the message is coherent, but this narrative or this meaning actually didn't or cannot construct this person's preferred identity, it will not provide agency for this patient or for this physician to move on with the treatment. So preferred identity is very important. So from their storytelling or story sharing, we can actually measure what is their preferred identity, whether this preferred identity is constructed during the process. This is identifiable. From the linguistics research or even communication research or even sociology research or narrative research, we have a lot of methods to measure that. So about identity. So this is my preliminary answers to your question, but I think this is very important and worth further investigation.
Thank you. Because I'm thinking of the relevance. Relevance on topic or relevance on theme. When physician and patient exchange information, opinion, and emotion. So when we develop SCDM model in clinical setting, to me, one of the key tasks is how to improve the level of relevance of our SCDM messages and talks and dialogues. Because the more our relevance, the better our agreement on treatment options
Yeah.
and decisions. So that's my guess as a researcher on health communication and public health. So
Yeah.
I just want to tell you how they think about the importance of message relevance or the topic relevance on the divided narratives at this moment. How do you think?
You mean message relevance? I didn't clearly get your question. You mean the divided narrative, how relevant
Yes.
this divided?
One of the keys to bridge the gap
Yeah.
in meaning making
Mm-hmm.
at this moment
Mm.
could be
Mm-hmm.
our effort to improve the
Mm.
level of relevance
Mm,
on our dialogue, our message.
Mm.
That's my suggestion.
Yeah.
Because given very limited time of
Uh-huh.
consultation, we
Yeah.
have to find out better indicator to reduce the gap, right,
Yeah.
in the
Yeah.
meaning. So that's why I'm just asking you, how do you think about the relevance?
Yeah, thank you very much. I think one part in our clinical setting we can improve when we apply a narrative perspective, because in our clinical setting we already have one step to collect history, disease history, right? So in this part, I saw in my field work, I saw some doctors actually they had a lot of information, personal information about this person, even family information. So this is already narrative information that you can pay attention to, like their family structure, their financial condition. So these are the things we can also keep in mind when we have communication with them. So then when you keep these issues in your mind, then during conversation, then you will be easier to identify which issue actually the patient concerns most. Then how this issue actually influence their identity construction. Because if I don't have money, then how can I be a good father? So I will choose not to take treatment. So these all are issues in their narratives, which will influence their decisions. And how can we collect the information of their narratives? It's not just about storytelling. It's about whether you pay attention to those elements in their narratives. Because you don't have time to hear their stories, and maybe they don't have ability to really tell you the whole story, because sometimes the story are very spontaneously developed. It depends on how you interact with this patient. There's no existing story there for you to find. So I think one part to apply this narrative perspective in clinical setting is we can just pay more attention of the information from narrative perspective. It's not only information, it's some part of the story that you can explore. And also, I want to say we actually don't aim to bridge the narrative gap, because it's about develop new narratives by both of you. It's not to like we will fill some gap. It's not necessary. That's all.
질문이 더 있으실까요? 혹시 네, 질문이 더 없으시면 오늘 7차 세미나는 이렇게 마무리하도록 하겠습니다. Dr. Lu, thank you for the wonderful presentation today. I hope you continue your excellent research. Thank you again. 예, 이렇게 마치도록
Thank you
하겠습니다.
very much, Professor Hong.
Thank you for your
감사합니다.
presentation.
Thank you so much.